ba? Their lecture na?
Opo, Dok.
Okay, so sige, let's start na the lecture ha. Saan na yun? Okay, can you see my screen?
Yes, doctor.
Okay, so my lecture is all about vaginal delivery. This is the chapter 27 of the 26th edition of Williams Obstetrics. So the objectives for this lecture is for us to know about the delivery technique, know more about what is a persistent occiput posterior position, and then knowledge about shoulder dystocia management, and then some special populations, third stage of labor, the lower genital tract lacerations, and the episiotomy repairs. So the delivery technique, this is the preparation. This is the end of the second stage of labor. So do you know how many stages of labor do we have? Any one of you knows?
4 stages.
So what are the 4 stages of labor?
First stage po, cervical dilatation po. Then, to delivery of the baby. And second stage po, delivery of the baby to the, then third stage po, the delivery of the placenta. And the fourth stage po is the recovery.
Postpartum recovery. Okay, that's true. So the first stage of labor is from the start of the labor or the start of cervical opening, which is usually at the active stage of labor, up to full cervical dilatation. And then the second stage of labor, it is from full cervical dilatation up to delivery of the baby. And then the third stage of labor, it is the placental delivery. And the fourth stage of labor is the postpartum period. So the end of second stage of labor, it is heralded as the perineum begins to bulge and the fetal scalp is seen through the separating labia. So there is a perineal pressure from the fetal heads that create a reflexive pushing efforts. So the mother will push once she felt the perineal pressure caused by the fetal head. At that time, we have to do a fetal heart rate monitoring. So if you have a nuchal cord that tightens during fetal descent, this may lead to deepening or the variable deceleration. So you already know, di ba? What are the types of deceleration? So if you have a variable deceleration, this is usually related to the cord compression. So during umbilical cord compression, so during fetal descent, and since the nuchal cord tightens, then there is a variable deceleration. We should also take note about the bladder distension. So once the bladder is distended, we must catheterize it so that it can provide a added pelvic space during labor and delivery. So ito yun. These are the stages of labor. Usually, we place the mother in a dorsal lithotomy position, in which this is the most common and most satisfactory position during delivery. The legs, the leg holders and stirrups are often used in order to assist a good way of delivery. We also take note for the perineal lacerations. The legs are usually separated, but it should not be too widely, or it should not place one higher than the other. Then the legs are not strapped into the stirrups in order to permit a quick flexion of the thighs backward into the abdomen, and this will also help during the shoulder dystocia event. The legs may also cramp during the second stage of labor or second stage of pushing. So the cramping can be relieved by creating a gentle muscle stretch or by brief massage or both. Regarding the vulvar and perineum, it is very important that we do cleansing. And then once the patient is already in full cervical dilatation and about to go to second stage of labor, the sterile drapes are placed to cover the legs and abdomen, and we should only expose the perineal area only. Then that's the time that we should do the scrubbing, gowning, gloving, and the donning by using a protective mask and eyewear to protect not only the accoutreur or us, the doctors or midwife, but also the patient from the infectious agents. So by the end of the second stage of the labor, the position of the occiput is usually known. So you have to know already yung position ng head. And the most common position of the occiput is usually occiput anterior, or it could also be rotated slightly oblique. The molding and caput formation may have precluded early accurate identification. So only 5% of those having a vaginal delivery have a persistent occiput position or occiput posterior. So sometimes the persistent occiput posterior can lead into cesarean section. Kasi there are reasons behind bakit nagkakaroon tayo ng malposition, which is the persistent occiput posterior. Medyo mahirap kasing i-deliver yung mga ganito na position. So, when do we say that it's already crowning? Crowning is usually happen when there is, in which each contraction causes a vulvovaginal opening that is dilated by the fetal head. And then it will gradually form an ovoid and almost circular opening. This is the encirclement of the largest head diameter by the vulvar ring. So we have two methods or approaches in delivering the head of the baby. We have the hands-on method and the hands poised method. So the hands-on method, ito siya, the thumb and remaining fingers are usually used to form a V press against the perineum to bolster it. The other hands maintain the fetal neck flexion to deliver the smallest head diameter through the introitus, and this will provide a gentle pressure against the rapid forward movement to avoid a expulsive delivery. So ito siya actually. Ganyan yung gagawin. But the difference with the hands poised method, this is also now known as hands-off technique, in which the hands touches neither the head or perineum but are applied only selectively to slow rapid head expulsion. So yung hand poise method is they don't use the hands. Ito yung sinasabing V press. Ito yun. So ito yung sa hands-on method actually. Yung sa hand poise method, we don't usually use it. Pero, pwede pa rin siyang gamitin para lang ma-guide or mag-guard natin yung perineum sa further laceration. So, there is what we call applying no pressure or only applying a minimal pressure on the fetal head to control the expulsion rate when rapid expulsion and perineal tears are likely to occur. So in this case, there is a lower episiotomy rate. There is what we also call the Ritgen maneuver. We have also the modified Ritgen maneuver. The Ritgen maneuver, this is where the glove fingers grasp the fetal chin. The fetal chin just behind or in the anus, and then there is an exertion of an upward pressure between contractions. So as a counter, the other hand presses against the occiput to control forces against the perineum. Alternatively, if expulsive efforts are inadequate or an expedited delivery is needed. So in modified region maneuver, it only uses the sterile towel. And then there is almost the same. There is a moderate upward pressure applied to the fetal chin by the posterior hand, and then while the occiput is held against the symphysis pubis. So almost the same lang. Pero take note by using the sterile towel and the occiput is held against the symphysis pubis. So medyo minodify lang yung region maneuver na original. Now, let's go for the delivery of the shoulder. So following of the delivery of the fetal head, delivery of the shoulder is will be the will proceed to the delivery of the shoulder. Here, the finger is passed across the fetal neck just to determine whether it is encircled by one or more umbilical cord loops. In cases of nuchal cord incidence, this increases with gestational age and is found in nearly 25% of deliveries at term. So, if there is an umbilical cord coil felt, you have just to slip over the head to loose it enough. And then if it's too tightly, the loop is cut between the two clamps. So there are two ways. If it is loosened, you can slip the umbilical cord to the back or to the back area of the baby. Whereas the other one, if you have a tight nuchal cords, you can cut between that. You can put two clamps at once habang nandun pa yung head nandun pa yung shoulder sa loob. So once na nakita nyo na yung umbilical cord na tight siya, pwede na kayong mag-clamp agad and then cut it na para maloosen and ma-deliver si baby. So tight nuchal cords can complicate approximately 6% of all deliveries, but not associated with worse neonatal outcomes than those without a cord loop. Putting the fingers in the axilla is avoided. Why? Because it can injure the upper extremity nerves and produce a transient or possibly a permanent paralysis. Immediate nasopharyngeal valve suctioning of the newborn was routine to remove the secretions previously. But as of now, suctioning of the nasopharynx may lead to neonatal bradycardia, according to some studies. According to the American Heart Association, neonatal resuscitation, they recommend that we must avoid suctioning immediately following birth, even if it has a meconium. It is meconium stain. Because with meconium stain fluid, as the routine intubation for tracheal suctioning is actually also not recommended, especially if the neonates is vigorous. And sometimes also for non-vigorous neonates, they don't advise a routine intubation for tracheal suctioning. So, when do we do the suctioning? Suctioning is only reserved for neonates who have obvious obstruction to spontaneous breathing or who require a positive pressure ventilation according to Wyckoff in 2015. Suctioning options are valve syringe or a suction catheter aspiration and may include intubation suctioning if the airway is really obstructed. But in my practice, sometimes gusto ko pa rin that I do the suctioning kasi there are cases that we cannot, hindi na namin mahabol yung baby kapag pinaiyak namin once it is meconium stain, then pinaiyak namin agad. So, lalo na kung nakikita mo naman na there are lots of secretion in the neonate's nose. So, better, ako personally, pero yan yung nasa studies kasi, and yan yung sinasabi nung nasa libro. So, yan. Based lang naman yan sa experience. So, when do we do the cord clamping? So, the umbilical cord is cut between two clamps placed 6 to 8 centimeter from the fetal abdomen. And then later on, the umbilical cord clamp is applied 2 to 3 centimeter from its insertion into the fetal abdomen. So, for vigorous term neonates, umbilical cord clamping is actually ideally delayed for 30 to 60 seconds in order to transfer blood to the newborn. However, in general, delayed compared with early umbilical cord clamping does not worsen the Apgar's or our umbilical cord pH value. So, halos wala rin naman daw ganong significance. But, as of now, based din sa DOH natin and WHO, they still advise a delayed cord clamping because of the transfer of blood to the newborn. Let's go to the occiput transverse position. So, according to the book, the pelvic shape leads to a persistent occiput transverse position. So that is not easily overcome during stage of pushing. There are two types of pelvis that are associated with persistent occiput transverse. Those who have a platypeloid pelvis and android pelvis. So ano yung platypeloid? I think you've already they already lectured this para medyo nagkakaintindihan tayo. So the platypeloid pelvis, usually this is flattened antero-posteriorly. So mapapansin mo yan sa mga babae, may mga babae na flat yung puwet nila. So usually they are the platypeloid type. And then those with android pelvis, this is a heart-shaped type. So usually the heart shape, medyo may pagka-flatten din ng, medyo bilog siya, pero dito sa bandang likod, hindi maganda kasi heart shape. Medyo mas, masikip at the posterior area, dun sa may sacral area. So the reason behind it is because of the space. Because the space may be inadequate for the occiput to rotate, either to anterior or posterior. So once na hindi siya nag-rotate, it will be stuck to occiput transverse. So in the absence of pelvic architecture abnormality or asynclitism, the occiput transverse position is usually transitory. So pwede siyang magbago. However, hypotonic contraction usually rotates the head spontaneously to an occiput anterior. So yun yung gusto natin kung may hypotonic contraction. So if rotation ceases because of poor expulsive forces, vaginal delivery can be aided also by giving some additional medications like the oxytocin. Manual rotation can be done para to make it into occiput anterior. Yun yung ideal position kasi in delivering the baby. It should be occiput anterior. And then, aside from manual rotation, they can use also the Keelan forceps in which it can rotate the occiput anteriorly. For the persistent occiput posterior position, this occurs around 2 to 10%. So many fetuses delivering occiput posterior are actually in the occiput anterior during early labor. So there is actually a malrotation during labor, so nagiging occiput posterior siya. So most of the time, mataas yung chance na ma-cesarean if you have a persistent occiput posterior or sobrang hirap talagang mag-deliver yung mother kapag persistent occiput posterior or POP yung baby. So what are the risk factors behind this POP? It is due to epidural analgesia, nulliparity, there is a greater fetal weight, and history of OP position on her previous deliveries. And again, because of the pelvic shapes, the anthropoid pelvis and a narrow subpubic angle. There is, yun nga, there is a higher rates of higher rates of cesarean delivery and operative vaginal delivery because of this. Kasi the POP can cause a prolonged second stage of labor. So women who deliver vaginally, they have higher rates of blood loss also and the OASIS, that is the obstetric anal sphincter injuries. Sometimes then digital examination can be inaccurate. So what increases the accuracy? By doing the transabdominal sonography. Siyempre, during delivery or labor, hindi naman na natin nagagawa itong transabdominal sonography unless we have a ultrasound machine or the portable ultrasound machine within the delivery room. Now, let's go to the shoulder dystocia. The anterior fetal shoulder can become wedged behind the symphysis pubis and fail to deliver with maternal pushing and gentle axial traction by the provider. So, the retraction of the baby's head against the mother's perineum is one of the sign that we have a shoulder dystocia. So, that is what we call the turtle sign. So, nakakita na kayo ng turtle, di ba? So, yung itsura niya, there is, yung head ng baby is nagre-retract kahit na anong hila mo sa head niya. So, yan yung what we call the turtle sign. The mean head-to-body delivery time in normal birth is usually 24 seconds. So, if we have already a more than 1 minute delivery or 79 seconds, that is considered a shoulder dystocia. So, the more than 1 minute ka na nagtatry to deliver the shoulder, that is considered a shoulder dystocia. For the consequences, it poses a greater risk to the fetus than the mother. For the maternal side, it has a serious perineal tears and postpartum hemorrhage due to uterine atony and from lacerations. And for the neonatal concern, there is a significant neuromusculoskeletal injury and asphyxia. So 11% of it can cause a brachial plexus injury, or some 2% it can cause a clavicular or humeral fracture. The risk factors are the following, such as fetal macrosomia, maternal obesity, prolonged second stage, history of operative vaginal delivery on her previous pregnancies, history of shoulder dystocia on previous pregnancies, and syempre, medyo takot tayo once we have a patient with maternal diabetes. Medyo magko-consider tayo for possibility of shoulder dystocia. So, a combination of fetal macrosomia plus maternal diabetes mellitus, it escalates the frequency of shoulder dystocia. So, what do? We can do a planned cesarean delivery. So, we usually offer for non-diabetic women and whose fetuses with estimated fetal weight of more than 5,000 grams, we already offer a planned cesarean delivery. But for women who has diabetes, we usually advise them for cesarean if they have a more than 4,500 grams estimated fetal weight. But actually, these are only American size to. So, sa ating mga Asian or Filipinos, actually, siya, kung titignan mo ha, based on my experience, 4,000 grams for diabetic woman, we usually offer a cesarean section na. And even sa mga pero for those who are multi-gravid, and it's 4 kilograms na yung baby, pwede naman silang mag-vaginal delivery. Lalo na kung maluwag din yung pelvis ni mother and has histories of big babies on their previous deliveries. Pwede namang i-allow. Pero pag mga diabetic and first-time mom na may 4 kilograms na, medyo nag-o-offer na rin kami ng planned cesarean section. So during the management and during management ng labor and delivery, it should be a labor and delivery team must be complete. Ito siya. So dapat we have nurses who knows how to do the shoulder dystocia maneuvers, and the obstetrical providers or the doctors, and the anesthesia staff. So, very important yan na dapat meron tayo yan if you are considering of a possible shoulder dystocia delivery. Pero, imagine mo naman, bakit naman natin gustong mag-deliver ng baby na sobrang laki? 'Di ba? So, mas maganda na lang sigurong mag-CS kaysa magkaroon tayo ng morbidities. Pero, syempre, there are cases na, especially in government hospitals, bigla na lang tayong madadatnan ng mga patients na who has a big babies talaga. So, hindi natin talaga rin siya ma-avoid. Pero, very important na we have a complete labor and delivery team. And, syempre, dapat may operating room tayo na available. So, kung lying-ins lang tayo, lying-ins or a RHU or mga community hospitals who doesn't have an operating room, medyo kailangan natin nang mag-refer to the higher center. Yun nga, very important that all the team should be well-versed in its management. Why? Our goal is to reduce the delivery time due to ongoing cord compression. And the second goal is to avoid fetal and maternal injury from aggressive manipulation. In doing the maneuvers, adequate analgesia is very important. And then episiotomy is important also to provide a sufficient room for essential manipulation. But this not actually lower a brachial plexus injury rates. So here, take note for the maneuvers. Ito siya. Actually, these maneuvers are in order. So ito yung mga first na gagawin natin, and then kung hindi siya naging effective, if these maneuvers are not effective, tsaka tayo maglilipat to the other maneuvers. So the very first maneuver that we are going to use during the shoulder dystocia is this one, the Mack-Roberts maneuver. This is the first maneuver that we must do. First, we have to lift the legs from the stirrups, and then the hips are sharply flexed up onto the abdomen, and the knees remain flexed. So ito, hindi pa siya, i-flex lang muna itong legs ang pinaka-important dyan. And then, followed by a suprapubic pressure that is directed down and lateral. So yung Robert maneuvers is actually If flex mo lang yung legs and then ililift mo from the stirrups and the hips must be sharply flexed din. Yun yung Mac Roberts maneuver. And then, once the Mac Roberts maneuver is not effective, we can add the suprapubic pressure. So, the assistant can apply a downward and laterally directed na suprapubic pressure. Ganito siya. So, anong purpose nito? This will abduct the anterior shoulder to create a shorter bisacromial diameter. This will also rotate the shoulders into the oblique diameter, which at the pelvic inlet is longer than the AP diameter. So, if not again successful, we move to other rotational maneuvers. Ito, delivery of the posterior shoulder. Ito siya. So, a hand into the posterior pelvis is carefully sweeps to the posterior arm of the fetus and forwarded across its chest and delivers the arm. And if possible, the operator's fingers are aligned parallel to the long axis of the fetal humerus to lower the fracture risk. Yan. Parang ihuhook mo the other hand will try na i-sweep niya yung posterior arm forward para medyo mag-widen yung bisacromial diameter or mag-shorten siya, sorry. Yan. And then, tsaka mo hihilain, you will pull the arms palabas. So, yung isang arm, yun yung padideliver mo. So, ano nga ba yung tinatawag nating bisacromial diameter? The bisacromial diameter, that is the distance between the outermost point of the fetal shoulders. Ito siya. Yun yung bisacromial diameter. If the rotational maneuvers are not effective, we can do the Rubin maneuver. This is another rotational maneuver. This is recommended by Rubin in 1964. This also, the aim is to shorten the bisacromial diameter also, and the hand reaches the most easily accessible posterior or fetal shoulder, and yun nga, most often the posterior one, and then push toward the anterior surface of the chest. The maneuver abducts the posterior shoulder and rotates both shoulders into one of the pelvic inlets of oblique diameter. So there is friction from the vagina that abducts the anterior shoulder to some degree during this rotation. So the resolution of the disproportion can free the anterior shoulder. If again not effective, we continue it with, or we convert it into a wood corkscrew maneuver. This is another rotational maneuver in which you rotate the posterior shoulder progressively in a corkscrew fashion. In this one naman, the anterior shoulder could be released. One hand is pressed against the anterior surface of the posterior shoulder and the pressure is directed toward the fetal back. So, the posterior shoulder is actually rotated with 180 degrees. And in case hindi pa rin siya effective, we can move into Gaskin maneuver. The Gaskin maneuver is also known as the all-fours maneuver. The parturient or the mother rolls onto her hands and knees. So, ganyan yung position niya. And there is axial traction against the head, neck, and attempts to free the posterior shoulder. So, yung posterior shoulder yung free natin ulit dito. However, ano yung challenges that we can encounter with the Gaskin maneuver? This includes the immobility due to the regional analgesia given and the time loss in patient repositioning. Ito siya. So, this, in summary niya, ito yung flip-flop daw para mas easily ma-remember. You flip the mom over to the gaskin. Ito siya. So, dadapa siya from there. Then, dadapa. And then, you lift the legs parang in a running start yung position niya. Ganyan yung nangyayari sa gaskin maneuver. And then again, kapag di pa rin naging effective yung gaskin maneuver, we convert into posterior axillary and axilla sling traction. So the target again is to deliver the posterior arm. If the posterior arm is inaccessible, so pwede naman yung anterior. But medyo mahirap lang siya. Kasi you insert a suction tubing or a STP urinary catheter and threaded under the fetal axilla, and both ends are brought together above the shoulder. So these will form a loop beneath the axilla, and the catheter traction then sweep upwards and downwards to deliver the shoulder. So the data continue to accrue. So in case series of 119 cases, this was the first maneuver and the success rate was 96%. Pero medyo higher yung risk natin na magkaroon tayo ng brachial plexus injury. If again, hindi ulit effective, we can fracture the anterior clavicle by using the thumb to press it towards and against the maternal pubic ramus. So in practice, deliberate fracture of large neonate's clavicle is actually difficult. If ever maging successful siya, don't worry about the fracture because it will heal rapidly and is usually trivial compared with brachial plexus nerve injury, asphyxia, or death. If worse comes to worse, we can do the symphysiotomy. So ito siya, ang sakit. No? Because it involves cutting the intervening symphysial cartilage and its ligament to support to widen the symphysis pubis. And then, the Sabanelli maneuver. The Sabanelli maneuver, this involves replacement of the fetal head into the pelvis followed by cesarean delivery. So, i-rotate natin yung head into occiput transverse, and then ibabalik natin yung head papasok. So, what we usually do, we give a terbutaline in order to have a uterine relaxation. The operator will turn the head to an occiput anterior or occiput posterior, and then it will slowly elevate its back into the vagina, and then cesarean delivery will then be performed. Lastly, the cladotomy. This consists of cutting the clavicle with scissors or other sharp instruments. So in this case, the cladotomy, usually the fetus is already dead. Siyempre, di ba, sa sobrang tagal na nandun nang na-stuck si baby, yan na yung pinaka-last resort natin kung ayaw nating isubject yung patient into cesarean section. So, So in summary, this is the shoulder dystocia video. Dito mas maiintindihan nyo further yung management. So, 8 minutes ito. Just watch and listen.
Para there's no sound po.
Walang sound.
Yes po, Dok.
Okay, wait lang ah. Hmm, paano to? Walang yeah, naririnig niya na.
Wala pa din po, Doktor.
Wala pa rin.
Wala pa rin po, Dok.
Wala pa rin.
Meron na po, Doktor.
Hi, my name is Julia Boucher.
Nakikita niya?
Student
Tapos
from
po meron na din po sa Doktor.
Today we're going to be
Okay.
talking about the diagnosis and management of shoulder dystocia. Shoulder dystocia is a complication that can occur during a vaginal delivery. It is an obstetrical emergency. Shoulder dystocia occurs when, after delivery of the fetal head, additional obstetrical maneuvers are required to deliver the fetal shoulders. It occurs in approximately 1% of births. Shoulder dystocia can be caused by impaction of the anterior or posterior shoulder during vaginal delivery. Anterior shoulder is more common and is caused by impaction at the maternal pubic symphysis. Posterior shoulder is less common and is caused by impaction at the maternal sacral promontory. Risk factors for shoulder dystocia include maternal diabetes, suspected macrosomia, gestational age more than 42 weeks, previous shoulder dystocia, and operative delivery. However, over 50% of shoulder dystocia cases are not predictable and have no risk factors, so you need to be prepared for the possibility of shoulder dystocia at every delivery. Shoulder dystocia is a clinical diagnosis that should be made promptly. The diagnosis is made when the routine practice of gentle, downward traction of the fetal head fails to deliver the anterior shoulder. It is very important to diagnose shoulder dystocia as soon as it occurs. That way, the obstetrical team can start to manage it right away. The goal of management is to deliver the infant before asphyxia from umbilical cord compression occurs without causing any fetal or maternal trauma. So, now that we know how to diagnose shoulder dystocia, let's talk about management. There's a helpful acronym to remember the steps of how to manage shoulder dystocia. It's called ALARMR. Let's use a case study to go through the acronym and learn the management of shoulder dystocia. Sarah is a 28-year-old G1 at 40 weeks gestation that has been laboring for the past 10 hours. She is healthy and takes no medications. She has had a normal pregnancy so far. Sarah had an epidural to manage her labor pain when she was 4 centimeters dilated. Now she is fully dilated and has been pushing well for the past 2 hours. You and the resident that you are working with notice that the fetal head delivered, but then retracted back into the perineum, also known as the turtle sign. What do you and the resident do next? To answer this question, we need to go through our ALARMR acronym. This acronym is a step-by-step method to manage shoulder dystocia. Starting from the top, each step should be followed as necessary. It's possible that the shoulder dystocia resolves after the first step. Moving on to the next step is only required if the shoulder dystocia does not resolve. If you were to encounter shoulder dystocia on rotation, you may be involved in the first few steps. However, each step is progressively more invasive and requires an increasing amount of skill, so most of the later steps will be done by the resident or staff you are working with. Let's go through the acronym. A stands for Ask for Help. Depending on where you're working, this may mean pulling the alarm bell or asking a team member to call for additional staff. L stands for Legs. Specifically, 2 members of the obstetrical team need to stand on either side of the patient and hyperflex her legs. This is known as McRoberts maneuver. The patient's legs should be flexed all the way back so that her thighs are against her abdomen. This movement rotates the pubis symphysis and flattens the sacrum to relieve obstruction. This may be sufficient to relieve obstruction in up to 42% of patients. If the shoulder dystocia persists, move on to the next step. A stands for Apply suprapubic pressure and anterior shoulder disimpaction. To do this, one of the team members needs to grab a stool to stand on and then use their palm or fist to apply downward and lateral pressure suprapubically. This maneuver adducts and rotates the fetal shoulders to disimpact the anterior shoulder. Another way to disimpact the anterior shoulder is using the Rubin maneuver. This is done by placing one hand in the vagina and on the back surface of the posterior fetal shoulder and rotating it anteriorly to disimpact the anterior shoulder. If you are unable to do so, move on to the next step. R stands for Release the posterior shoulder. To do this, one hand is placed in the vagina after finding the fetal arm, Flex the elbow across the chest to grasp the forearm or hand and pull it out of the vagina. If you can't deliver the fetal arm, it may be possible to deliver the shoulder. If not, move on to the next step. M stands for maneuver of Woods. This is also called the screw maneuver because you try to rotate the fetus or unscrew it by putting pressure on the clavicle of the posterior shoulder and rotating it until it becomes anterior. If none of these maneuvers work, E stands for episiotomy and can be considered. An episiotomy is a surgical cut made at the opening of the vagina to allow more room and better access to the posterior arm. The last letter of the acronym R stands for roll onto all fours. The patient is helped onto her hands and knees. This is in an effort to take advantage of gravity to facilitate delivery. If none of the steps of the acronym work, there are several last resort methods that can be considered. However, these are associated with a significant increase in fetal and maternal morbidity. These include fracture of the fetal clavicle, Zavanelli maneuver or returning the fetal head and attempting a cesarean delivery, and symphysiotomy, separation of the maternal pubic bones. Now that we know the acronym, let's return to our patient Sarah. Sarah had been pushing well for 2 hours when the obstetrical team noticed the turtle sign. You and your resident suspect shoulder dystocia and initiate the alarm or acronym. The resident asks for the staff to be called and the dystocia bell to be pulled to alert the rest of the staff. The first step, ask for help, is complete. What's next? You and one of the nurses start to hyperflex the patient's leg for the McRoberts maneuver. L for legs is complete. Unfortunately, the shoulder dystocia persists. What's next? Apply suprapubic pressure and anterior shoulder disimpaction. A nurse you are working with steps on a stool and shows you how to properly apply suprapubic pressure, downwards and laterally towards the baby's head. Luckily, the combination of McRoberts and suprapubic pressure relieves the impaction of the anterior shoulder and the resident is able to deliver the baby. Congrats! You have helped deliver Sarah's baby by promptly diagnosing and managing shoulder dystocia with the help of the alarm or acronym. Let's review the key points from this video. Number 1. Shoulder dystocia is an obstetrical emergency that requires prompt diagnosis and management. Number 2. Diagnosis of shoulder dystocia is made when the routine practice of gentle downward traction of the fetal head fails to deliver the anterior shoulder. Number 3. Alarmer provides an acronym for the management of shoulder dystocia. Can you remember what each letter stands for? A stands for ask for help. L is legs hyperflexed or McRoberts. A applies suprapubic pressure and anterior shoulder disimpaction. R release posterior arm. M maneuver of Woods. E episiotomy. And R roll onto all fours.
Okay, so naintindihan niya naman.
Yes po.
So actually, the alarmer is, we usually offer that or we use the alarmer during our residency training and during our exam. But for the lecture coming from our book, we don't use the alarmer here. Pero kung titignan mo, very important siya kasi actually that's the summary of the shoulder dystocia management. Mas mapapadali siya kapag alam natin yung alarmer or yung alarm method. No? So yun nga, very important if we have a patients who are we are considering the baby na macrosomic siya or with macrosomia. And the mother came in inevitable na yung delivery. very important that we have a complete team, no? So yun yung pinaka-una doon. You have to ask for help kasi very important yung buong team ninyo is dapat marunong regarding dun sa shoulder dystocia. And then that will follow na po yung iba't ibang maneuver natin such as the Mac-Roberts maneuver, suprapubic pressure, enough episiotomy, and then the anterior arm delivery in the suprapubic pressure, and then if you cannot still deliver, then to follow yung mga posterior arm maneuvers natin. So yung home birth naman, according to DOH and WHO nun, by year 2020 or 2020, kaya nagkaroon ng lying-in sa Philippines is because of yung aim nila or the goal is to have a zero maternal death. So they usually avoid or they don't advise patients to give birth at home na. Pero in other countries or back in previous years, home birth are usually allowed for patients who are low risk and that benefits for fewer medical intervention, like you don't have to do a labor augmentation, episiotomy, operative vaginal delivery, and cesarean section. So usually, those patients who do the home birth are sila yung mga multigravid na. They are the who have second pregnancy, third pregnancy na previous vaginal deliveries who are uncomplicated. Now, let's go for the female genital mutilation. In other countries, usually in African area, they practice this. This practice actually refers to a medically unnecessary vulvar and perineal surgical modifications. The parturients with types 1, 2, and 4, they only typically require only routine obstetrical care. But for the type 3, female genital mutilation, there is an extensive scarring leading to higher delivery risk. When we say defibrillation, this is a division of midline scar tissue to reopen the vulva. This is also called as de-infibulation or anterior episiotomy. Based to WHO classification of female genital mutilation, we have the 4 types. The type 1, which is the partial or total removal of the clitoris or prepuce. The type 2, a partial or total removal of the clitoris. Then this includes the labia majora with minora with or without the labia majora excision. For the type 3, this is a partial or a total labia minora or majora excision, and then followed by fusion of the wound, termed infibulation, to cover and narrow the vagina. So this type 3 may have a clitoridectomy, may have or may not have. And then for the type 4, this is the pricking, piercing, incising, scraping, cautery, or other injury to female genitalia. So pinaka-common siya in African areas. Pero in Indonesia, some part of Asia also, pina-practice ito because of their religious belief. Like yung sa Indonesia, Malaysia, may mga nagpa-practice pa rin nito. Now, let's go for the anomalous fetuses. The delivery can be obstructed by extreme hydrocephaly, body stalk anomaly, conjoined twins, or massive fetal abdominal enlargement from a greatly distended bladder, ascites, or organomegaly. So, sometimes questionable if these fetuses can be delivered via normal delivery or cesarean. So, in cases of milder forms of hydrocephaly, vaginal delivery can be allowed naman as long as the biparietal diameter is less than 10 centimeters and the head circumference is less than 36 centimeters. In cases of babies who has IUF, who are already demise or stillbirth na sila, the vaginal delivery can be a reasonable delivery type. In cases of hydrocephalus or fetal ascites, it can be reduced in size for the vaginal delivery. How? By removal of fluid by doing the cephalocentesis or paracentesis, but with ultrasound guidance. The clidotomy can also shorten by cutting the it can also shorten the bisochromal diameter in doing the clidotomy. And then for hydrocephalic fetuses that are in rich presentation, you can do a cephalocentesis by suprapubic removal. And then the aftercoming head will enter the pelvis. So these practices are more germane in developing countries. But during my residency training, we already did the cephalocentesis and then the paracentesis during delivery of the baby. Actually, it's not through sonographic guidance. So if you know Dr. Pico Reyes, that is our consultant during our training. We delivered a baby who has fetal ascites, and during that time, that patient, she didn't have any prenatal checkup to the hospital, and under siya ng private consultant. Then the patient was actually advised for cesarean delivery. However, the patient came into the training institution, and then inevitable delivery na siya. Kumbaga, dahil crowning na siya nung dumating. And then, hindi niya sa amin sinabi na may abnormality yung baby niya. Eventually, nagkaroon kami ng shoulder dystocia during that time. And then, sad to say, dahil nagka-shoulder dystocia kami, hindi namin ma-deliver yung katawan ng baby, namatay yung baby during that time. And then, tsaka lang sinabi ng mother, nung hirap na kaming mag-deliver, that, na meron palang fetal ascites sa baby. So, yun, tinawag namin yung consultant namin, si Dr. Rico, and then, he did the, paracentesis. Pero, through vagina yung approach namin. Nagparacentesis kami through vagina. So, eventually, na-deliver namin yung baby. Hindi na namin siya na-CS kasi na-release naman namin yung water from the abdomen. Kasi yun yung nagkukos ng hindi paglabas ng baby. So, do you have any question ba? Na intindihan niya naman yung lecture? So, if you don't have any question, then let's proceed to the third stage of labor. So, the third stage of labor is about the delivery of the placenta. This actually begins immediately after fetal birth and ends with placental delivery. So, the goal here is to deliver an intact placenta, and very important is to avoid the uterine inversion or what we call the postpartum hemorrhage. So in order to prevent the uterine inversion, umbilical contraction, we must not pull the placenta from the uterus. So hindi daw dapat sobra yung pag-pull. Pwede naman natin medyo i-pull, pero with support. So yung support that I'm mentioning is actually the Brandt-Andrews maneuver. The Brandt-Andrews maneuver, this is the expression of the detached placenta in which the hand is not trying to push the fundus. So, we are not trying to push the fundus through the birth canal, towards the birth canal. This in which the placenta leaves the uterus and enters the vagina, and then the uterus is pushed cephalad by using the heel of the hand on the abdomen, and the cord is held in position. Then the mother can aid in the delivery of the placenta by bearing down. Pero we must advise also the patient na not too much naman in bearing down. As the placenta reaches the perineum, the cord is lifted, and then it in turn lifts the placenta out of the vagina. So that is the Brandt-Andrews maneuver. So ang dami yung mamememorize na mga maneuvers with this lecture. So here we have the signs of placental separation. You have to take note kasi ito during clerkship. If I don't know if you have your clerkship in Fabella. Sa Fabella ba ang clerkship pa din? Ito kasi usually tinatanong nila and even in the exam. So what are the signs of placental separation? One is there is a sudden gush of blood into the vagina, followed by the uterus becomes globular and firmer, fundus. There is lengthening of the cord and elevation of the uterus into the abdomen. These signs appear within minutes after newborn delivery, and the median time ranges is actually from 4 to 12 minutes. For the management of the third stage of labor, it can be expectant or active. For the expectant management, we just have to wait for the placental separation signs and then allow the placenta to deliver either spontaneously or aided by nipple stimulation or gravity according to WHO in 2012. And then for the active management, we do the earlier cord clamping and then a controlled cord traction during placental delivery and an immediate prophylactic administration of uterotonic agents. So what are the uterotonic agents that you know?
Oxytocin.
Aside from oxytocin, what else? The methyl ergometrine or the metergine. So according to them, delayed cord clamping does not raise a postpartum hemorrhage rates. Thus, early clamping is a less important component of this trio or the active management. For the cord traction, once the cord traction fails to prevent actually the hemorrhage. Traction does a lower manual placental during the third stage of labor. So yun nga, the uterotonic drugs, they play an essential preemptive role to decrease the postpartum blood loss. And then, a single agent is given either before or after placental expulsion. I usually give it after the placental expulsion. Sometimes kasi, if you give it very early, the cervix or the lower uterine segment of the uterus, usually nagko-contract siya. So there is already nagkakaroon ng constriction dun sa LUS and then affected hanggang sa may cervix. Kung medyo mataba pa yung placenta, then medyo nahihirapang ma-expel yung placenta. So sometimes I give the uterotonics after the placental expulsion. Pero that is a case-to-case basis. Depende na lang when you practice na lang. So timing does not affect the rates of postpartum hemorrhage, placental retention, or third stage labor length. So ito nga, these are the uterotonic drugs. Our first line is oxytocin. The misoprostol or the cytotec, ito syempre, regulated drug to actually, and they, hindi siya actually na natin masyadong ginagamit kasi bawal siya. Pero kung medical needs naman, yun, pwede naman. Basta doctor gagamit. Kasi ito yung ginagamit nilang pang palaglag yung mga iba. No? And then, aside from that, we use also the metergine or the ergot rate. Pero itong ergot rate, hindi pa ako nakakakita masyado dito. More on metergine. And then, if we want a long-acting one, we can give the carbetocin. So, high-dose oxytocin. Synthetic oxytocin is actually identical to that produced by the posterior pituitary. And then, the action is approximately 1 minute and its half-life is 3 to 5 minutes. The storage temperature of this oxytocin should be less than 25 degrees Celsius. So, nawawala ng effect kapag masyadong, kung nasa room temp natin or nasa lang natin siya, nasa loob lang siya ng labor room. So, dapat naka-ref ito. Kasi, di ba, the temperature now in the Philippines is sobrang init. Nabot tayo ng 45 to 50 degrees Celsius. So, once na na-expose natin itong oxytocin in a, higher temperature, hindi na siya ganun ka-effective. So, yun nga. So, much better if we store it in the, ref. Kasi, the storage temperature is less than 25. Then we can give the oxytocin via diluted intravenous infusion or via intramuscular. Pag IV, it should be diluted. Hindi siya, So what is the, side effect? Kung masyadong bolus, if you give it too bolus, it can cause a profound hypotension. So the dilution is actually 20 units in 20 units of oxytocin or 2 ml of oxytocin placed in a 1 liter of crystalloid solution. So after the delivery of the placenta at a rate of 10 to 20 ml per minute for a few minutes until yung uterus becomes firm and bleeding is controlled. The infusion then can be reduced to 1 to 2 ml per minute pag gusto mo, once you want the patient to be transferred to the postpartum unit. And those patients who delivered in a lying-in or in a BIMONG center, we usually give the 10 units of oxytocin intramuscular. Pero slow din yung pagbigay natin intramuscular. Here, the methyl ergonovrin or the metergine, the side effect is BP elevation. So, if you have a pre-eclamptic or eclamptic patient, we don't usually give the metergine. So, oxytocin. Take note that the oxytocin can cause a profound hypotension, whereas the metergine can cause a BP elevation or hypertension. So, magkaiba sila. So, if we have a patient who are already in hypovolemic shock, hindi na tayo talaga nakakapagbigay ng oxytocin. Why? Kasi, lalong bumababa yung blood pressure. So, that's the time na we can give the metergine para tumaas yung BP ng patient. So, how do we give this? This is given intramuscularly. And if ever given intravenously, it should be not less than 60 seconds in infusion. So, hindi siya pwedeng ibigay IV ng sobrang bilis. So, usually, we give the metergine IM. For the misoprostol or the Cytotec, they use this in a resource poor settings that lack the oxytocin supply. Pero here in the Philippines, we don't usually give this kasi nga pinagbabawal siya. The misoprostol can be given as a single 400 or 600 microgram dose. What are the side effects? It can cause fever and diarrhea. And then the carbetocin carbitocin actually is more expensive. Pero ito na yung mga bago. In cases that the oxytocin, metergine are not effective, this is ito yung binibigay namin, the carbetocin. This is heat is stable and may have benefit in low resource settings that may have inconsistent temperatures during supply distribution. So ito, pwede siya dito sa Philippines kasi heat is stable siya. And then the tranexamic acid. The tranexamic acid, this is not a uterotonic agent. This is an antifibrinolytic agent and has been evaluated to prevent the postpartum hemorrhage. Pero the tranexamic acid is given via intravenous infusion in a slow infusion rate. And then, we have to take note also in patients na those patients who have may mga clotting problems kasi hindi natin siya pwedeng basta-basta ibigay for patients who have clotting problems or history of strokes. So, causes of undelivered placenta or prolonged third stage of labor. Placenta adherence. This is a adherent placenta. And then, yun nga, yung sinasabi ko kanina, once the LUS constrict, the placenta will be trapped. So, kaya I usually give the oxytocin after placental delivery. And then, cases of placenta accreta spectrum. Yan yung kasama actually yung adherent placenta, placenta accreta, and the placenta percreta. Ito yung mga abnormalities. So, ito yung mga reasons why nagkakaroon ng cases of prolonged third stage of labor or undelivered placenta. So, what are the risk factors for retained placenta? Those patients who have history of stillbirth pregnancy, prior cesarean delivery, prior retention delivery, preterm delivery, and actually yung mga history of curettage, sila yung risk factors for retained placenta. So the spontaneous delivery of the placenta would depend on the weeks or the age of gestation. For 20 weeks, actually matagal, 2 hours na mahigit, 3 hours, 180 minutes, so 3 hours siya. So matagal. So that's why sometimes we do curettage dito kasi nagkukos na siya ng bleeding if we didn't deliver the placenta at once. And then for 30 weeks, 21 minutes. And then for 40 weeks, pwede nating mahintay for 14 minutes. But, according to WHO, the threshold is 60 minutes. This is how we do the manual removal of the placenta or the manual extraction of the placenta. The one hand grasping the fundus and the other hand is inserted into the uterine cavity and the fingers are swept from side to side as they advance. And then once the placenta detaches, this is grasped and removed. For the immediate postpartum care, we have to check the lacerations and should be repaired. Yun, then followed by giving of uterotonics. In cases of expanding hematomas, we have to release the hematomas. In cases of hematomas less than 5 centimeter and not expanding, sometimes we don't evacuate it anymore. Hinahayaan na natin siya as long as less than 5 centimeters and non-expanding. However, if the hematoma is more than 5 centimeters and it's expanding, syempre very important, kailangan natin siyang i-evacuate. Sometimes we do it in the operating room. Pero kung kaya naman in the delivery room, sa delivery room din ginagawa. So, every After the delivery of the placenta, we monitor the blood pressure every 15 minutes for 2 hours, the temperature every 4 hours during the first 8 hours, and then every 8 hours thereafter. Why do we have to do it? Para ma-check natin if there's a puerperal sepsis. Vital signs may be obtained and more frequently in patients of higher risk of postpartum complications. The placental membranes and umbilical cords should be examined for completeness and anomalies. So the skin-to-skin contact, the aim is to connect the mother and newborn early to promote breastfeeding. For the lower genital tract lacerations, we have the first degree, second degree, third degree, and the fourth degree. For the third degree laceration, this involves the anal sphincter and they are subcategorized as 3A, 3B, and 3C. For the 3A, the external anal sphincter, there is a 50% external anal sphincter tear. And for 3B, more than 50%. And then for the 3C, the external plus the internal anal sphincter is affected. So the third and fourth degree perineal lacerations are the ones who are considered part of the OACs or the obstetrical anal sphincter injuries. So these are the different types of or degrees of perineal laceration. Here, this is the first degree perineal laceration and the injury is only the vaginal epithelium and the skin. And then the second degree laceration, this spares the anal sphincter complex. But this actually, the muscles, perineal muscles are involved. So what are the two perineal muscles? This is the bulbus sponjosus and the superficial transverse perineal muscle. For the 3A, less than 50%. So this is the external anal sphincter. So less than 50% of the anal, this one, sorry. So ito yung third degree, fourth degree na. Fourth degree na yun kasi the internal and the external na siya. So ito yung less than 50% in 3A, more than 50% external anal sphincter. So this is the external sphincter. And then for the 3C, this is the external anal sphincter and this is the this is the internal anal sphincter. So sa 3C, na siya, kasama na yung internal anal sphincter. And then the 4C, fourth degree, the perineal body, entire anal sphincter complex, and the anorectal mucosa is already cut. So pati ito. So kita mo siya. This one is ito lang, hanggang dito lang sa internal for the 3C. But for the fourth degree, the rectal mucosa is already affected. So there are two main types of episiotomy, the midline and the mediolateral. So the midline, this begins at the fourchette, incises the perineal body, and ends well before the external anal sphincter. The chosen incision length varies from 2 to 3 centimeter depending on perineal length, degree of tissue thinning, and outlet diameter needs for delivery. The midline episiotomy is actually okay for those patients who has a wide or mas makapal or mahaba yung perineum nila. for the medial lateral, usually it's more on the right, di ba? Mas right-handed tayo. So, the right medial lateral is the one that we usually use. This begins at the midline of the fauci and directed to the right or left in an angle of 60 degrees of the midline. There is a less time and suture time for the repair. And this is the preferred incision. Why? Because there is a reduced oasis rate. So unlike in midline, there is a chance of ano sphincter injury in midline episiotomy. There are other types of episiotomy. Hindi na siya na-discuss, but aside from these two episiotomy types, meron pang maiba. May J-type, ganun. So this is a picture of a medial lateral episiotomy. So once the baby's head is already in a crowning stage, then the fingers are insinuated between the perineum and the head. The incision begins in the midline. So dun muna siya sa gitna. So and then directed to the ipsilateral ischial tuberosity with an angle of 60 degrees. From the midline, tapos convert mo siya na 60 degrees to the right. So that is the right medial lateral episiotomy. So in doing the medial lateral or the episiotomy repair, we usually use the chromic 2O. Pero dito, according to the book, you can use different types of sutures. Siya. So this is how we repair the anal sphincter. So this is the internal anal sphincter. We use the continuous stitches. And then for the external sphincter, we have the simple interrupted suture using the chromic 2O or we can also use the Vicryl or the polyglactin. So here in the external anal sphincter, we have the 3 o'clock, this is the 3 o'clock, and then the 6 o'clock, and then after the 3 o'clock and 6 o'clock suturing, we can do the figure 8, and then followed by the 9 o'clock and 12 o'clock suturing. So posterior, inferior, and then figure 8, anterior, and then superior. So that is how we repair the external anal sphincter. For the 4th degree laceration, so ito siya, we usually we suture it by doing the non-locking method again, the continuous suturing. And then the suture should not be through and through the rectal mucosa. So parang in between lang siya para ma-avoid natin yung rectovaginal fistula later on. Yan siya. Okay, so that's the end of my lecture. I hope you've learned something. Did you understand my lecture? So we have only 89 participants in this Dr. Claire, can you get the attendance again?
Okay po.
Do you have any question regarding this lecture or naintindihan niya naman? So Ang medyo mahirap lang naman sa part na to is the shoulder dystocia actually. And then you have to know all the maneuvers. And then during your clerkship, anong year na kayo? Second year or third year?
Second year po.
So may ano pa, 2 years